So to wrap up this lecture, let's talk a little bit about some of the treatments and the pharmacology that we use to take care of these arthritides. In order to understand these drugs, we have to have a brief review of the drugs that act on the eicosanoids. So the eicosanoids are the arachidonic acid products. So there's a picture on your screen now that sort of shows you this pathway. And let's go over it briefly. The way this works and the way that these eicosanoids are produced is that in the membrane of cells in your body, you have membrane lipid called phosphatidylinositol. This membrane lipid gets converted into arachidonic acid by an enzyme called phospholipase A2. So phospholipase A2 takes these membrane lipids and converts them into arachidonic acid. Now corticosteroids, which we'll talk about separately in another lecture, have many different mechanisms of action when it comes to reducing inflammation. One of their mechanisms of action is actually to inhibit this enzyme, phospholipase A2. And by blocking that enzyme, you're actually decreasing the amount of arachidonic acid produced and thereby reducing the amount of all of its eventual metabolites that are all pro-inflammatory. Now, phospholipase A2, once it creates arachidonic acid, that arachidonic acid can be worked on by two different enzymes. One of them is called lipoxygenase. And if lipoxygenase works on the arachidonic acid, it will convert it into a series of molecules called leukotrienes. So arachidonic acid gets converted into leukotrienes by lipoxygenase. If lipoxygenase does not work on the arachidonic acid can also be acted on by a different enzyme called cyclooxygenase. And cyclooxygenase is also known as COX. And there are two varieties of COX. There's COX-1 and COX-2. Now, COX-1 is expressed in certain tissues, and COX-2 is expressed in different tissues. COX-1 can be found in the GI system, in particular in the stomach, as well as in platelets. Whereas COX-2 is found in a lot of different cells in your body and is primarily responsible for producing inflammation. So to review so far, we have membrane lipids being converted into arachidonic acid by phospholipase A2. Then that arachidonic acid can be worked on by one of two enzymes, either lipoxygenase, which will convert it into leukotrienes, or by cyclooxygenase, COX-1 or COX-2, which will convert arachidonic acid into a series of different molecules, which we'll go over now. The first possible molecule that can be produced by COX-1 and COX-2 would be prostacyclin, also known as PGI2. Prostacyclin has antiplatelet properties, so it's actually antithrombotic, so it decreases platelet aggregation and causes some vasodilation. So that's prostacyclin. Think of it as an antiplatelet inflammatory mediator, antiplatelet. Now, the COX enzymes can also produce prostaglandins. Now, prostaglandins are going to have several effects throughout the body. One common prostaglandin is PGE2. It causes a decrease in vascular tone, causes an increase in pain, an increase in uterine tone, and an increase in temperature. So I tend to think of PGE2, or prostaglandins, as pro-inflammatory mediators. And then lastly, we have thromboxane, which is also produced, again, by COX enzymes taking arachidonic acid and converting it. Now, thromboxane, also known as TXA2, is a very pro-platelet. Okay, so this causes a lot of platelet aggregation and vasoconstriction. So wherever you have a platelet plug trying to form, you're going to have a lot of thromboxane present. So to review, the COX enzymes will produce prostacyclin, prostaglandin, and thromboxane, all of which have slightly different effects in the body. And again, COX-1 is primarily in the GI system and in platelets. COX-2 is in most cells in your body and is responsible primarily for inflammation. Okay, this is important to keep the distinction in your mind between COX-1 and COX-2 for the side effects of these drugs. We will discuss that shortly. Now, on the opposite side of this pathway, as we said, if the arachidonic acid is worked on by lipoxygenase, you're going to get leukotrienes. And there are several different types of leukotrienes. One of them would be LTB4. And LTB4 is primarily responsible for neutrophil chemotaxis. So it attracts neutrophils to a site of inflammation. The other three leukotrienes, and you don't necessarily have to know their names, just know that they're not the ones that are LTB4. So just remember, LTB4 does neutrophil chemotaxis, and the other three are responsible primarily for bronchoconstriction. They act in the lung. Now, there are a number of medications that act all over this pathway. We're going to discuss each of them in detail now, but I think it helps to go over them briefly while we're still looking at this diagram. So corticosteroids, as I said, will act to inhibit phospholipase A2. They will also work to actually inhibit the protein synthesis that leads to the COX enzymes. So you get overall less COX enzyme production with corticosteroids. There's also a drug that blocks the enzyme lipoxygenase, and by blocking that enzyme, decreases all levels of leukotrienes. That drug is called Xileuton. And Xileuton, Z-I-L-E-U-T-O-N, as I said, inhibits lipoxygenase and decreases levels of all leukotrienes. Now, if the leukotrienes are produced, there's also a drug you can use to block them at the receptors in the lung. These are going to include montelukast and zafirlukast. So these Lukast drugs will block the leukotriene receptors in the lung and will decrease bronchoconstriction. So we sometimes use these drugs for asthma. Now, going down the COX pathway after arachidonic acid is formed, we generally use NSAIDs to block the COX enzyme. These are non-steroidal anti-inflammatory drugs. These are actually non-specific and will block both COX-1 and COX-2. Acetaminophen will also have some properties of blocking both COX enzymes. And then aspirin, as we said, is going to block both of the COX enzymes. And lastly, we have COX-2 inhibitors, which are actually selective only for the COX-2 variant of the COX enzymes. And as I said, we'll go over each of these in some details in just a few minutes. The first drug we'll discuss in some detail is aspirin, very commonly used drug. Now, aspirin irreversibly inhibits cyclooxygenase by covalent bonding. So as long as aspirin is in the system, it's irreversibly binding COX enzyme. It's non-selective, so it acts on both COX-1 and COX-2. And so you decrease the synthesis of both thromboxane and prostaglandins. So aspirin technically is an NSAID. Now, clinical use of aspirin is going to be low dose, less than 300 milligrams a day, if you're trying to decrease platelet aggregation. So usually you'll hear about patients with heart disease or ischemic heart disease taking a baby aspirin each day to help prevent acute myocardial infarction. Intermediate doses of aspirin, so 300 to 2400 milligrams a day, are primarily used for its antipyretic and analgesic properties. And if you get up to very high dose aspirin, which is rarely used, we're talking about 2400 to 4000 milligrams a day, it will have very good anti-inflammatory properties. Now, the side effects of aspirin are not trivial. They're quite important. Gastric upset is the most common, and patients will actually develop upper GI bleeding in some situations. And the reason for that is that, as I said, COX-1 is expressed in the stomach, and COX-1 is really important in maintaining the mucosal lining of the stomach via production of prostaglandins. And so if you block COX-1 in the stomach, you're going to block prostaglandin production, you're going to decrease the mucosal lining of the stomach, and you're going to be more prone to ulcers and gastric bleeding. So very important not to use aspirin in patients prone to gastric bleeding. Chronic use of aspirin, because it is an NSAID, can also lead to acute renal failure, interstitial nephritis, and actually in children can lead to something called Reyes syndrome. And when children are treated with aspirin to reduce their fever and pain during a viral illness, they can develop this condition called Reyes syndrome, which really affects the liver and the brain, so they can have liver failure as well as encephalopathy. And so we highly recommend not using aspirin to treat a viral illness in children. One other important side effect to be aware of with aspirin is aspirin-induced asthma. And as you might guess, since aspirin is irreversibly working on the COX enzymes, you're going to be blocking the prostaglandins from being produced. And prostaglandins tend to cause bronchodilation in the lungs. And as you said, the leukotrienes tend to cause bronchoconstriction. So if you're blocking prostaglandin production, but you're not affecting the leukotriene production, you've got an imbalance between bronchoconstriction and bronchodilation in the lungs, and patients can actually develop an aspirin-induced asthma. Now, the other NSAIDs besides aspirin include things like ibuprofen, naproxen, indomethacin, and ketorolac. All of these reversibly inhibit the COX enzyme. So whereas aspirin was an irreversible inhibitor, the COX enzymes are reversibly inhibited by NSAIDs other than aspirin. And as I said, by blocking COX enzymes, you're just reducing prostaglandin synthesis and reducing inflammation. Clinical use for NSAIDs includes antipyretic properties, analgesic, and anti-inflammatory properties, and sometimes we use indomethacin to close a patent ductus arteriosus in an infant. Toxicity, as I said, is similar to aspirin. You're going to have renal damage. Sometimes patients with that renal damage will end up holding on to too much fluid, so they get fluid retention and congestive heart failure. You can have an aplastic anemia in rare cases. GI distress, in particular, bleeding and ulcers are also common, again, because you're blocking COX-1, which is responsible for maintaining the mucosal lining of the stomach. Now, recently, certain drugs called selective COX-2 inhibitors have been produced. Now, these are NSAIDs as well, but instead of non-selectively binding the COX enzymes, they only block COX-2. Now, why might this be a desirable property in a drug? The reason is that if you're only blocking COX-2, you're able to fight the inflammatory mediators like prostaglandins, you're able to decrease those, but you're not affecting COX-1. And so the idea here is that you're not going to cause the GI issues such as bleeding and ulcers. So this is very good to use in a patient who is prone to GI bleeding. The problem that's been found, however, is that these actually cause an increased risk of thrombosis, such as acute myocardial infarction. And then also, patients with sulfa allergies cannot use COX-2 inhibitors. Now, the most commonly used one is called celecoxib. It's usually used for rheumatoid arthritis or osteoarthritis. Next, we have acetaminophen, which is extremely commonly used medication for pain. This also reversibly inhibits cyclooxygenase, or COX. However, other than NSAIDs, where NSAIDs are working in the periphery to reduce inflammation, acetaminophen really works in the CNS, so the central nervous system, and that's how it actually inhibits cyclooxygenase and will cause decreased pain. So with that, you're going to have antipyretic and analgesic properties, but you're not going to have the true anti-inflammatory properties because the drug is not working in the periphery the way that NSAIDs do. So it's very good to use acetaminophen in children instead of aspirin to combat the symptoms of a viral illness, because again, remember, we don't want children to develop Reyes syndrome. Toxicity of acetaminophen, the most important one to be aware of is that overdose, so taking too much, can result in hepatic necrosis. And the reason for that is that acetaminophen gets broken down into a metabolite that will deplete glutathione in the liver. And glutathione in the liver is needed to reduce oxidized free radicals. So if you don't have enough glutathione around, you're going to form a lot of different toxic free radicals in the liver, which will destroy the liver cells. So the treatment for acetaminophen toxicity is N-acetylcysteine, which tends to regenerate the glutathione that was depleted by acetaminophen toxicity. Lastly, there are a number of drugs we already mentioned that are used to treat the disease gout. The first is colchicine, which we said is primarily for acute gout, also used with NSAIDs. The way that colchicine works is by binding and stabilizing tubulin to inhibit polymerization of microtubules. This is important because leukocytes, such as neutrophils, rely on polymerization of tubulin in order to do chemotaxis and degranulation of their inflammatory mediators. Now, the main side effects of colchicine are going to be GI, such as diarrhea, and sometimes it's preferable to just try to use NSAIDs first, since they have less toxicity and are a little bit better for patients than colchicine can be. Another drug used to treat gout, although used for chronic gout, is going to be probenecid. This is going to inhibit resorption of uric acid in the proximal convoluted tubule, and it's also going to inhibit secretion of penicillin. So you should be aware that if a patient is taking penicillin at the same time, the levels of penicillin might get quite high in the blood if the patient is taking probenecid for gout. Then lastly, the primary treatment for chronic gout is going to be allopurinol. The way this works is by inhibiting an enzyme called xanthine oxidase. And as you may know, xanthine oxidase is responsible for converting xanthine into uric acid. And so clearly if you block it, you're going to have less uric acid production. Sometimes we'll give allopurinol prophylactically in a patient with cancer, or if they're about to undergo chemotherapy, because we're afraid of tumor lysis syndrome occurring and lots of uric acid being released into the bloodstream. Importantly, you should avoid using allopurinol in patients who are taking azathioprine or 6-mercaptopurine. In that situation, both of those drugs are metabolized by xanthine oxidase, so if you block xanthine oxidase, you're going to have very high levels of those very toxic drugs in the bloodstream. And then also, you want to avoid giving salicylates, such as aspirin, when you're giving something like allopurinol. The reason is that pretty much all but the very highest doses of salicylates are going to depress uric acid clearance. Even high doses, 5 or 6 grams a day, have only minor uricosuric activity. So again, avoid salicylates when you're giving allopurinol. So that will end our lecture on the different types of arthritis. And when we return, we'll have a more thorough overview of autoimmune disease as a whole, and we'll tackle the most commonly tested autoimmune diseases on the USMLE Step 1.